So I'm going to start just by defining what we mean by evidence-based practice, because it can mean many things, and so I'll just do that briefly. We're going to use the definition that's put forward by the American Psychological Association, mostly because we like it. So evidence-based practice has three parts. The first is the research evidence, which can involve a variety of types of research, but rigorous research looking at whether a practice works for a particular population or doesn't. So we start with that. But it's also important to include clinical expertise, right? Because the research tells us sort of broadly whether a practice works or not. It doesn't necessarily tell us whether it works with that child in front of you or not. And so your clinical expertise is the next important piece. And of course, we also want to consider the characteristics, the culture, the context for the family, for a classroom, for a clinic. So to understand how well that practice fits within that program and that culture and with that family and that child's needs. So all of those things together are what we're going to call evidence-based practice. Not just the research, we start with that, but we also want to include the other pieces. Any questions about that before we go? Okay, so that's what we're talking about tonight, and Dr. Schweitzer is going to start.
Thanks everybody for coming out this evening. I'm really happy to see people here. We know this is a really important topic because we get lots of questions about this all the time. We get it from the public, from parents, teachers, and so forth. What works and what doesn't work. And obviously as a parent or a consumer yourself, you want to use procedures and medications that are safe as well as effective. And if you go on the internet, oftentimes there might be misinformation or too much information. So we understand that this is a confusing topic. So we're happy to be here today to talk about this. I have a partner tonight. She's not physically here. Her name is Dr. Danielle Schulze. Dr. Schulze was a trainee here, a behavioral and developmental pediatric trainee, and she was here for 3 years, and it was wonderful to work with her, but now she's off to a faculty position at the University of Wisconsin. Many of the slides I'm using tonight are actually from Danielle, and she's done talks in this area because she is really interested in how you communicate information about what works and what doesn't work. So I couldn't do it much better than she did, so that's why we're using some of her slides. What you see up here right now are my financial disclosures. So this is where I receive some of my funding, the majority of my funding for my research. This is primarily money from NIH, National Institutes of Health, and I heard that they passed a budget this past week that was really healthy, and I'm really glad to hear that, and as taxpayers, we should all be grateful for that, because that's what funds so much of the work that we do. In the past, I have received money as well, some funding for some of our research from McKinley, which was for a treatment study. And I'm not sure if we'll touch on that study or not tonight. It depends mainly on the question and answer session. But it's important for you to know when we're talking about treatments and so forth, where our funding comes from. Okay, so I'm just going to go quickly through these so you can look at these. ADHD is not anything new. Since the 1700s, there were descriptions of it. Heinrich Hoffmann actually wrote some stories about fidgety Phil for his children to entertain them. He was a child psychiatrist. He did that in the 1800s. In the 1900s, we have, let's see if this works as a cursor. DSM came out, described hyperkinetic syndrome, and then one of the most commonly used treatments for ADHD came out, Ritalin, which actually was discovered in a stimulant in 1937 to work. Then people started dividing up. By people, I mean the scientists, talking about ADD versus ADHD, which then would confuse everybody, and we no longer use that distinction. We'll talk more about that later. We found out also that there's a high heritability when you look at the twin studies. So if you're a parent, you have ADHD, it's not so surprising maybe that your child has ADHD, because the heritability in ADHD is so high that it's one of the highest in all the psychiatric areas. And the CDC, within the 2000s and increasingly, is recognizing that the prevalence is growing for ADHD, and they're recognizing it as a serious public health problem. And really, this is not just for children, this is for adults as well. So when we think about ADHD, we're talking about symptoms that are in two primary domains, the inattentive domain and the hyperactive impulsive domain. So inattention is what we think about as trouble maintaining focus, losing things, being forgetful, not listening, disorganization, and so forth. Impulsivity and hyperactivity are really obvious in the younger children. These symptoms change with maturity, but that's when people are impatient, or they're children, they're on the go, they're running and climbing on things, but as they mature, it may be more hyperactivity on a cognitive level. But you may see their legs moving quickly, grabbing things off the table, talking a lot, and being impatient. But again, some of these tend to change in their form as people mature. You can have all of those symptoms, or you can just have the inattentive symptoms. If you just have the inattentive symptoms, that's what people in the public oftentimes refer to as ADD, but we refer to that as ADHD, inattentive presentation. The most common is when people have all these symptoms to some degree, and that's called ADHD combined presentation. It used to be that you had to have these symptoms before 7 years of age. Now we say it could be up to 12 years of age is for when they start. And about 2/3 of people continue to have some symptoms. Some actually increase in difficulty as people mature and they have other symptoms as well besides ADHD. And about 1/3 of people tend to lose their symptoms. We want to see that there's impact at home and school or work and home, so it's not just in one particular area to really qualify for the diagnosis. So we have lots of data right now suggesting this actually a neural problem, and by neural I mean that we have lots of studies from brain imaging, including the work that we do here, showing that people use their brains differently who have ADHD. It's also developmental, and the most important aspect of that is that as people mature, what you see is that their behavior doesn't seem to match what their developmental age is. So oftentimes people describe people with ADHD as acting young for their age. The guidelines we're going to talk about tonight are primarily from the American Academy of Pediatrics. They established guidelines in 2011, and that hasn't really changed much. There's been a few subtle changes because we have a new system that we use for diagnosis, what we refer as the Diagnostic and Statistical Manual, or DSM, and that's used primarily in psychiatry, but as well in pediatrics. And there are some nuances about that. I'll talk about that, but really, what the recommendations were in 2011 were good, and there's no major change in those. So that's what I'll be relying upon primarily for tonight. And so what they recommend, and AAP is American Academy of Pediatrics, is that the evaluation could be initiated if you're a pediatric physician between 4 to 18 years of age. I work with primary care physicians as well who work with adults. And it's important to determine whether people meet criteria. This says DSM-4 because this is from the 2011 guidelines, but now we're in DSM-5. And I'll go into more detail about some of these other areas, but it's really important to look at whether ADHD is occurring by itself, if it is ADHD, if there's other issues that may be mimicking ADHD as well, to recognize that ADHD is not something that occurs acutely. It is something typically, as I said earlier, that continues over time, and that you have to consider the developmental stage of the person's at, and also look at if you are using medication, that you're using the right type of medication, the right dose, and that you check on that frequently. So this is a little bit Dr. Sommer talked about earlier, is talking about the strength of the evidence. So randomized controlled trial, does anybody here know what a randomized controlled trial is? Oh, it does, that's good. Okay, anybody else in the audience? Okay, I see one person. Okay, so randomized controlled trials, that's the gold standard. That's when you take a group of people and you say, we're going to randomize, we're going to make it blind, we're going to say half of the group goes maybe into one condition and after treatment versus placebo, or maybe 2 different treatment conditions and so forth. The best ones are when people are blind to it, and by blind it means the patient doesn't know what treatment condition they're in, the experimenter doesn't know, the research assistants, and so forth. And so this way, it's really the active ingredient, the treatment, the experimental treatment that you're testing is what's having the effect, and not bias from what expectations are. So that's the best, and when we have RCTs, or randomized controlled trials, that means that's the best evidence that you can look for. But there's lots of steps along the way. So we start with oftentimes observational studies here. What Alvin alluded to earlier, your experience as a consumer, as a parent, and so forth in the beginning. And then we might look at observational studies to see over time what happens. Maybe they're not randomized and people aren't blind to it. But as the evidence accrues, hopefully you get to the point where you can do the gold standard. But they're much harder to do. They're much more expensive, and some types of interventions are very hard to do that way because some interventions, it's so obvious that you're using an intervention versus a placebo that it's not really, you can't really have a good control for that. So you need to consider that when you're looking at whether or not a treatment's been recommended, how strong is the evidence backing it up? That's really important as a consumer. So when a child comes to see a physician about ADHD, oftentimes they're referred by a parent. Obviously, they're bringing them in, but oftentimes we hear from the school as well. The schools are saying, your child's behavior is somewhat different than peers. They're having difficulty in the classroom and so forth. I really think you need to get that looked at. And that's oftentimes what they'll start with the primary care physician at that point. And they're looking at academic functioning, behavioral difficulties, interactions with peers, and so forth. I will say probably 80% of the reason people come into our clinic, maybe even higher than that actually, is because there's academic challenges. That's really what brings them into our door. Whether or not you should go along with this recommendation, actually, so I'm going to, on the bottom here, you'll see the strength of the recommendations here. So this is the quality of evidence is only a B, actually, not an A. So what might be the potential problems with going to a primary care physician and using this route? We'll talk about the benefits first. The benefits are that you're able to capture children who might not be diagnosed. So if you go to your primary care doc, that's the person who you see on a regular basis. You have annual appointments with. So it's a good time to bring it up if you haven't been told to go earlier by somebody else, such as a teacher. So that really helps. Primary care physicians are learning more and more about how to diagnose ADHD, and there's some really good systems for them out there. And they're going to capture some kids who might not be typically picked up. And we see variations about the frequency of diagnosis and so forth actually throughout the country. It really does depend on certain, actually school funding and issues like that as well. So they're going to capture people who maybe might not be normally picked up, which is great, but sometimes there's also some risks involved with that as well. And part of the problem is if they're going to see a primary care physician, oftentimes they don't have a whole lot of time. It could be that they just have 15 or 20 minutes. So they might not be able to do really in-depth evaluation. And if that happens, potentially then somebody could quickly get a diagnosis without looking at other potential reasons for why the behavior might be emerging and other problems as well. And so that's one of the harms or risks is that kids could be given the diagnosis and be given the treatment and might actually not need it and may be missing something else that really is critical to look at. And so what should you, when you're where you're working with a primary care physician or a psychologist or a developmental behavioral pediatric physician or a child psychiatrist, what should they be doing with you? They need to get a developmental history to find out if the symptoms that are happening have changed over time. You need to find out about basic milestones. Is there something else about the labor and delivery process and just generally how your child has been functioning? More and more people are recognizing the importance of finding out about sleep because we've actually had some cases where, in fact, I've had some in my clinic where children had sleep apnea and they had difficulty paying attention because they weren't getting enough sleep at night. You want to know about the family history. Is there a history of ADHD or other psychiatric problems in the family? Social history is critical as well. What are the peer relationships like? Is there something different socially right now? Has there been a divorce in the family? Have people moved and so forth? Because that can affect one's behavior. You'll expect them to give not just an interview, but also use behavioral rating scales. And behavioral rating scales vary in terms of their intensity. That means their length and the degree that they ask questions, and also the standardization practices. Ultimately, I believe the best rating scales are those that look at whether the child is a male or female and the age. And that's because we have norms at different ages, because as we said earlier, it's a developmental issue. So you have different expectations at different ages. And psychological testing is typically not required, but if there's any concern about a learning disability, then it is required. And there are certain other neurological issues that may also emerge that co-occur with ADHD that you want to look at, and sometimes neuropsychological testing could be helpful for that too. So I believe it's really important to look at comorbidities because they are very, very common. At least 1/3, if not more, of children with ADHD have other issues as well. And I'm not alone in that. American Academy of Pediatrics also suggests that. But you have to recognize that the typical pediatrician doesn't have the time to do that. And sometimes they don't have the expertise, so they'll have to refer elsewhere. And so why is that important? Because you want your child to be seen as a whole person, right? If they're having some issues with anxiety, if they're having some issues with academic problems as well, you want that to be looked at. So that's really important for that to be done. And if you don't do that, the problem is that it may be something else besides ADHD, or, like I said, if you're not treating the whole person, some of their ADHD symptoms may not improve as well, and you're just going to miss other factors that are going to impact their outcome and how well they're going to do in life. So these are some of the common conditions that occur with ADHD, and as people mature, you see more of these. Tourette's and tics, mood symptoms. In females, we're starting to see in the adolescents and young adults, we actually see a higher rates of suicidal intent and actual suicide attempts, so that's really important to look at. In adolescents, we highly recommend that you think about substance use disorders as well, if there's problems with the child being erratic and so forth, because we know that people with ADHD have a much higher vulnerability for substance use disorders, whether that's marijuana, alcohol, so forth. So behavior therapy, that's the most commonly known treatment for ADHD, and there's actually pretty good evidence for much of it, particularly for the non-ADHD symptoms actually. And so what can you expect when you sign up for behavior therapy? Usually it starts out with education about what ADHD is. Oftentimes also we work with the parents to help teach them how to describe the child's behavior, and the reason we do that is because the next step is really we want you to be reinforcing positive behavior, and sometimes it's hard to do that if you're not very good at actually paying attention to what your child is doing step by step. It's very easy to focus on the negative, and when you teach people to describe behavior, they start learning about some of the positive behavior, and we really want parents to highlight that more with their children. So it's typically about 8 to 12 sessions. And it's not infrequent as a child matures that you'll need more sessions because the symptoms might change as they develop. So these are some of the areas that really change and what we focus on. Where, as I said before, we teach people to describe behavior because you want to do positive reinforcement. You might also want to work with the school as well. Behavior therapy, all in all, has been shown primarily to actually work on the symptoms that occur around ADHD. So they don't change the hyperactivity. What they do is they change your relationship with your child and how you respond. And there's more here about some of the other areas of focus and what they do change. So your child's more likely to listen to you. So they're more likely to be compliant. You also want to teach parents to use behavioral principles so they can generalize them to new settings. So you might be teaching them how to interact with their child at home, but you want to make sure when they're out in a public place how to apply those same behavioral principles. Parents like really participating in behavior therapy. They like doing it one-on-one, but I think there's great value in doing it in a group, and some of that is because you're learning from other parents, and there's also a lot of validation from hearing other stories that parents have, what they're undergoing as well. Classroom management is also one of the cornerstones of what people do in terms of addressing ADHD issues, and that's where you typically work with the teacher and you develop a behavior plan, and if your school has a learning specialist or a school psychologist, they can work together, they can do an evaluation, and some schools are really excellent. They may have an IEP or more likely a 504 plan, and they can make accommodations and so forth and really help the child be more successful in the class. Having a partnership with the teacher is really critical. That obviously gets harder as they're in middle school and high school because they have more teachers, and teachers honestly have less time sometimes to do some of these things. So these are 3 very well recognized treatment packages for young children. They have really strong evidence, and if you Google them, you'll find them. There's nuances in terms of how they work between the 3 different ones, but in general, they work really with building the relationship and helping teach the parents how to respond in a positive way and key in on the positive behavior. And like I said, they have very good evidence. So what do we know about preschool age children? Occasionally we have some children who have behavior that's a major challenge and is interfering with their ability to stay in their preschool. I, a number of times, have worked with families where the child's been asked to leave 3 different preschools. And obviously this is very disruptive for the family. When it gets to that point, the first step, or in any situation, whether it's severe or less severe, is you want to start with behavior therapy. That is a very clear recommendation that's put forth not just by the American Academy of Pediatrics, but other societies as well. Medication should be considered if it's at the point where the behavioral practices do not seem to be working. And there is evidence that medication does work for young children, but there's disappointing information as well, suggests that people are more likely to start medication before they even try the behavioral practices. So you want to start with those initially. The elementary school years, again, there's good evidence for medication. There's very strong evidence. Behavior therapy, there's again, we recommend it, but one has to be realistic about what the behavior therapy does. Again, it's not going to change ADHD symptoms. It's more about how you interact with your child, and it may also help with other symptoms like oppositional defiant disorder, anxiety, and depression. For adolescents, again, medication, there's good evidence for it, but we do see a change in that in adolescents, many teens do not like to use medication. There's a lot of stigma about it, and they reject it. And so that, I think, is our biggest challenge, is that even though medication works, the compliance rates are very low. And then we don't have really great behavioral treatments for teens with ADHD. There are some really interesting novel ones that have come out, and the evidence, I would say, is moderate at this point, but at least people are looking at adolescence as a time to do something different. And that is really important, because a lot of times people are just trying to apply the same treatments for childhood as in adolescence. And it just doesn't work because the context is so different in terms of the autonomy and teens wanting independence and so forth. And also we now know in adolescence that the brain is still really developing. And that gives us also more options for treatment, but it also suggests that we could maybe develop treatments that are more specific to the brain development we see in adolescence. And that is actually an area that we hope to go into in my lab in particular. So we think that there are some opportunities that haven't been taken before. So right now, there's not a whole lot of great options for adolescents, but that still, if you have a really strong tutor, a strong coach working with them, and the medications at this point, that's what we recommend. Cognitive behavior therapy has been tested for decades in ADHD, and they discovered in the 90s that it does not work for children with ADHD. So cognitive behavior therapy is different from behavior therapy. Behavior therapy is when you specifically look at a behavior and you provide a consequence, hopefully typically a reward for positive behavior. Cognitive behavior therapy works on the idea that one is planning ahead and thinking. You're focusing more on the cognitions, the thoughts about the behavior. So a concrete example would be the next time you sit with the child and say, okay, what are you going to do when you go into the playground the next time you see Johnny and Johnny is playing with a toy that you love? And the child, what they teach them to do is say, okay, next time I see Johnny, I'm not going to take it from him, I'm going to walk away, I'm going to talk to a teacher, etc. So that's where you're focusing on what your cognitions are and your plans, rather than being in the moment. And for kids with ADHD, that just does not work, because they can tell you what you want to hear in the session, in the clinic, and they may really mean it, but when they're out in the playground and they see Johnny and they see that toy that they want, they're in with the moment. That's that impulsivity. Now, there's a difference for adults. For adults, it looks like there's some strong evidence I shouldn't say strong, but there's moderate evidence that cognitive behavior therapy works. So there are some nice manualized programs out there. And perhaps that's because people are more mature and they have a better ability to really reflect upon their behaviors, and they do have more self-control at that point. So for adolescents, they're at the point where they're starting to look for it, but they don't know at this point that it actually, there isn't strong evidence at this point for cognitive behavior therapy. People have been looking at mindfulness, and particularly at UCLA, and there's actually some evidence that might be useful. So medications we talked about earlier, I was less specific, but the stimulant medications that were discovered and started really being prescribed in the 1960s, they're pretty much the same ones. The change in them is a delivery system. So that means it used to be that they work for a few hours, and now they work for a longer period of time. And there's some other nuances in terms of how the medication works, but they work primarily in the same neurotransmitter systems, and there isn't much difference over decades. There are other treatments as well. Atomoxetine is probably considered the most effective of the non-stimulants, but it's not considered as effective as the stimulants, and there are some other medications here. Sometimes you're using a combination with the stimulant medication. So those are all the standard treatments that I talked about. There's lots of non-standard treatments, what we call complementary and alternative treatments of ADHD, and I just listed a few. And as I said, there's a lot of them out there. And the evidence is mixed. I felt like there was starting to be some good evidence for omega-3. Now it's not so clear. Yoga, we did a study here that showed some promising data that suggests that we should look at it some more in depth. Elimination diets, there's not much evidence for that, but if your child has a particular allergy to something and they've been giving that regularly, of course that's going to affect their behavior. But what's really important is that if you are going to consider supplements or something that you take in this area, like the omega-3, any of those, elimination diet, that you discuss it with your physician, because that's really important, because you want to make sure that you're taking something as safe. Just because something is sold as natural or an herb doesn't mean that it's safe. So that's really important to consider. There is a website that has some pretty good information. That's the National Center for Complementary and Integrative Health. So those are what we know at this point. I would say from my work in the neuroscience area, the area that's getting to be really interesting is looking at neurostimulation. And those are also techniques that I'm being told or you can purchase on the internet. And at this point, there's not much evidence for it, but people are very seriously looking at neurostimulation. So that's something to be considered in the future. At this point, we're still recommending that behavioral interventions, and one looks at educational evaluations and interventions as well, and you look at the whole person, so you're looking at comorbidities. That's really important, and you look at how people mature and whether you want to change what you're doing. It's again, because it is a chronic disorder for most people, you really want to look at their developmental stage, but not just also biologically what their clock is, the context that they're in. Is there something that's changed in their school environment, with their friends and so forth as well? And during the question and answer session over here, I'll be happy to share some of the resources, because there are a lot of really good ones out there nowadays. And I will transition to Dr. Stein. Thank you.
So I'm very jealous of the clarity with which we can recommend what to do for kids with ADHD. You will see that we don't have that clarity for autism, perhaps due to the comprehensive nature of the challenges that kids with autism have and the great deal of heterogeneity across the different types of symptoms. So heterogeneity in the social symptoms, in the repetitive behaviors, in language skills. Not that kids with ADHD aren't all different, they are, but the ways that kids with autism can be different make deciding what treatment to use a challenge. But we do know that we have interventions that help kids with autism in a variety of ways. We know that outcomes are variable for kids, and there's a lot of overlap between the tested or evidence-based interventions. So I'll talk a little bit about that. And that no one specific treatment method has emerged as the standard of care for all kids with autism. And really, we don't have a lot of comparisons of one treatment with another treatment. We're comparing treatment to not having treatment. And generally, if we're comparing two good treatments, kids do well in both treatments, which is confusing yet lovely, because when we take into consideration the context, it means we have a lot of options. So, which ones are evidence-based? There are multiple now kind of agencies that have reviewed the evidence base for autism. And on the resource sheets that you have, there are these websites, so they are available. But the National Autism Center has done a review of evidence-based practices, and they are constantly updating it, which is lovely. And so their review, they have a giant report, they have a nice summary of their report, and then they've also pulled out the evidence-based practices that are specific to schools in a way that teachers and educational providers can use it, and they've done a parent's guide as well, which pulls out information specific to help parents understand the evidence-based practice, which is the one I read, because it's much clearer than the other ones. But they really outline what counts as evidence, how strong the evidence is for each practice, and the limitations that we have to our research. So the other place that kind of simultaneously was funded to do a review was a National Professional Development Center for Autism. And so they have reviewed practices, both kind of individual practices and comprehensive programs for children up to 21 years of age. And part of the reason for that is because we don't have a lot of interventions and information yet. For most of the interventions we have are for preschool to school age kids. So I am happy to say that the National Institutes of Health have put out special calls for retraining researchers to look at transition and adult issues, special calls for people who want to look at intervention, and there is now a new journal specific to adolescents and adults with autism. So I think we're getting there. People know this is important and are studying it, but we don't have enough information or enough kind of replications of studies to have a lot of information about what's an evidence-based practice. So if you feel like I'm focusing on younger kids, it's because that's where the information that I have available to me is. But if we have time at the end, I will show you the this website, and it's, oh, I guess it's in blue up there, but it's also on the resource form. They have wonderful trainings in all of the evidence-based practices that I will talk about, videos you can watch, checklists. It doesn't provide coaching, which we know we all need to do a practice well, but if you want to learn about a particular practice, it's free, and they have lots of information, probably more than you want. But it's great. So these are the 27 evidence-based practices for autism that were identified in their recent 2014 update, okay? 27, that's a lot. So I want to talk a little bit about the overlap. Some of these practices are like one little strategy. The reinforcement that Dr. Schweitzer was talking about, that's up there as an evidence-based practice. Most likely you wouldn't do that alone. Some of these are pretty complex, like doing structured play groups or a functional behavior assessment. And so it's a little bit challenging to categorize things. So if you're looking for a particular intervention, and we'll talk about how to do it, sometimes you got to dig a little deeper into what these things mean, and that website can be really helpful for that. So let's talk a little bit about what's the same and different about some of these interventions. So one of the primary interventions we think about when we think about autism is applied behavior analysis. So I want to talk a little bit about what we mean by applied behavior analysis, because oftentimes a myth that comes up is that applied behavior analysis is the only evidence-based practice for autism. I hope that you leave here thinking that is not true, because we have a variety of practices. And I also want you to think about the breadth of applied behavior analysis. So the intervention that we talked about for ADHD was based on the principles of applied behavior analysis. The principles of applied behavior analysis were really the main part of the very first interventions that were studied for autism. So we have the most data on those because they've been studied for 40 years now. So that's, I think, where this comes from, but it is a myth that that's the only one. As we get new data, we have new tools. And so applied behavior analysis is a system of research, right, where we systematically apply these principles to improve behavior, right? And so it's not even a treatment. It's really a way to study an intervention. So one of the other myths that comes along with that is applied behavior analysis is always very highly structured and breaks things down into really small pieces. And so I think we think about that when we think about applied behavior analysis for autism. We think about something called discrete trial teaching, where things are broken down into very small pieces. Kids can learn. It's an evidence-based practice, absolutely, but it is not the only evidence-based practice for autism that's based in applied behavior analysis. So I just really, the chance for me to be on my soapbox, because you guys have to listen, it's really important, I think, to understand that discrete trial teaching is one of the tools that comes under this umbrella. Lots of different interventions with lots of different acronyms are also based on applied behavior analysis, and one or another may be something that fits your client, your culture, your setting, and works just as well. All right, so another myth is that applied behavior analysis and developmental sciences are not compatible. And again, I think this just comes from these different practices kind of growing up separately and people having their little camps. I'm a behaviorist. I'm a developmental scientist. But what we're really learning now is these things are not incompatible. And in fact, probably the best interventions systematically combine both of these things. And probably they have been all along, they just haven't been talking about it using the same language. So I think that's really important to remember when you're looking at different programs. So now when we think about, especially again for younger children, there's a move toward more naturalistic interventions. So interventions that are not sitting at a table doing a specific thing, although those may have a place, but also thinking about how to use our skills in the natural environment in a way that's a little bit more like other kids learn and more motivating for the kids with autism who are learning, right? And so these are a combination of behavioral interventions and developmental interventions. Kind of here, we're calling these naturalistic developmental behavioral interventions. Totally made up name by people who are doing this as a way to sort of say, here's another umbrella we can use for all these different brand names that people need to study to help people understand what's common among them. So some well-established naturalistic developmental behavioral interventions, and we do training in a couple of these, so I'll just give that. There are nuance, similar to like the different interventions for ADHD, there are differences in these, but in general, they're relatively similar. And they're all kind of focusing on social communication skills and developmentally appropriate skills for young children with autism. Lots of them have parent-implemented components so that parents can learn the strategies. Some are developed for schools. Some are developed for specific social tasks, but in general, the strategies are very similar. And I say that because it may be that some of these practices are readily available in the place where you live, and others are not. And sometimes I think it feels like, well, I need to get that particular treatment. But if you get one treatment on this list, you probably don't need to get 2 other treatments on this list, or certified or trained in them. They're pretty, I mean, they're not just totally interchangeable, and I'm sure the people that made them up wouldn't want me saying that, but they're kind of pretty interchangeable. And so I think it's nice to know that you can pick the one that is available, and training might be there, and coaching might be there, and get really good at it, and not have to just be moderately good at 10 different things. So there were 27 evidence-based practices for autism. How do I decide what to do with Johnny right here when he comes in my office, or my child at home? It's not that easy, and we're not that good at it yet. I keep waiting for someone to develop an app where we can put all those characteristics in and up pops the perfect treatment. But so far, the only person who can tell us which treatment works well for the skills we're trying to teach is the individual with autism that you are trying to teach those skills to. And so, of course, we want to start with looking at the components that make up evidence-based practices. And so when we're thinking of what treatment to start with, it's always nice to start with the evidence, right? So we want to have the idea that we want to have the best bet, right? We want to pick something that we think is going to work. And so starting with things that we know and have been shown to work is a nice way to start, right? And so this is a table that I have totally stolen from the National Professional Development Center for Autism. So they have and this is just a piece of it so you can see it, but they have all the evidence-based practices listed, right? These are different evidence-based practices across the top, and obviously it's not all of them, so it's big enough to see. And then the domain you want to teach, okay? So this helps you get a start to what you want to do. So say we have a child who's 2.5, recently had a diagnosis, and I want to teach them a few different skills. So I want to teach them communication. This child needs to learn some play skills and also has some challenges with self-regulation. So I might look on here and think, okay, what domains do I want to look at and what behaviors might I use? So for communication, we have a lot of choices of what might work. And for self-regulation, we have fewer choices for what might work. And then here we have play, has pretty many too. So what I probably want to do is look at the overlap. This one works for all 3. And these work for 2 out of 3. So I might think about which of these I have training in, which of these are available in my area. I might want to start with a behavioral because it has all 3, but if I'm really interested in another one, I can think about doing one of those and one of the ones that works well for self-regulation. Or I might try and see what happens with the behavioral, and that doesn't work. I might go to something that really targets self-regulation, right? But this gives me a place to start. The second cool thing they have is they have each evidence-based practice by age, right? So maybe some of those practices are shown to work with some ages and not others. And again, I'm only going up to 21, and you can see I don't have a lot of choices yet, right? But hopefully that's going to change. So my little one is 2.5. So I'm going to look at age, I'm going to look at intervention, and I see there are a few interventions, but it kind of decreases the number that I have if I just look at 0 to 2, 3 to 5. We got the most study right here. If you're a preschooler, you got evidence-based practices coming out the windows. So I probably want to look in both those areas because this child's going to turn 3 pretty soon. So I might think I want to start with behavioral, but I can also think about these more complex interventions because this child's going to be 3 pretty soon. Does that make sense? So this is where I'm starting. On that website that I showed you, we've got definitions of each of those interventions, the age ranges, the types of outcomes, articles where you can go to the primary source to really learn more about it if you want to pick those top 3 and then kind of dig in. Because then you're also going to need to consider those other aspects, right? What is your context? Are you a teacher? Are you a speech pathologist? Are you a parent? Are you a physical therapist? Like, this is going to matter in terms of what your program is. Is it a group program? Is it a one-on-one program? What supports are available in your area? And then what does the family want? What works for that child? Okay? So you need to think about what skills the child needs to learn, their learning style. Are they going to learn better in a very structured intervention or a more naturalistic intervention? Are the parents, based on their culture, their parenting style, going to be more comfortable with a naturalistic style or behavioral intervention? Are you, if you're a professional, like I know I like some interventions better than others just because they're more fun for me, and other people have different opinions. And so because we're getting good results with both of them, start with the one that works for everybody, right? What are the child's interests and motivators? And then, again, the parents' feelings about the intervention. But the most important thing, you got to start somewhere, and that's where we start. But the way to know when to change is taking data on the child's behavior. Because time and time and time again, we'll meet a child, we'll meet a family, we'll have the perfect intervention, we'll start, and that child will say, I'm going to prove you wrong. I'm not going to respond well to this intervention. I don't like it. It's not working. So we really need to understand, are we making the change we want to make in the behaviors that we're trying to target? And if not, we need to go back to our list and figure out a new plan. And that may vary by the skill you're trying to teach, by the setting you're in, by who's doing the teaching. And that is what makes this super complicated. But we do know that if you're not seeing progress in 3 or 4 weeks on a particular behavior that you've written really nice objectives for, and that website will show you how, that it's time to think about what you need to do differently, and that child or individual is going to tell you when that change needs to happen, either with their behavior or with their progress. And that's how we make those decisions based on their needs. So my kind of summary is that we do not have a silver bullet for autism. And as soon as we do, I am really happy to find a new job, so we will not hide it. And there's not one of those evidence-based practices that's going to be best for everything. So really, you want to find one that fits your system of care, your home, your organization, your beliefs and values, and what the child needs. That's how we're going to do it. And that's the only way we can do it. What I will say is when you do pick an intervention you want to use, learn it and use it well. So you really want to learn how to use it to what we call fidelity, or the way that it was supposed to be used, because the only way we test those practices is by using them well. Once you know it well, I will say you can adapt it because you really understand what works and what doesn't. What's really challenging and what hasn't worked is just pulling a lot of things very unsystematically and doing an eclectic model. We may use multiple interventions, but we want to understand how, when, and why we're using them, and we want to use them well. And so these learning modules have checklists to help with that. And again, learning one intervention very well is probably going to be more effective than learning 20 interventions not very well. Okay. So lots of toddler modules here. So they have a separate call out for very young children, how to coach parents, how to integrate very developmental practices, as well as some resources are coming out for older individuals with autism as they get the information available. So the National Professional Development Center is working on these projects for older individuals as well.
Isn't a dichotomy here sometimes between ADHD and autism? There's certainly a number of children who have both. And that is a change within the past few years in terms of what we could diagnose clinically, but certainly parents for years have told us, and treatment providers have actually been providing treatment as well. So it's sometimes it's not always clear, especially when children are young, whether it actually is ADHD or autism, but certainly people can experience both of the symptoms and need treatment for both. So the question here is, what is the difference between stimulant and non-stimulant medications? And the primary difference is what neurotransmitters they work on the brain. The stimulants are very much, they target dopamine and typically a little bit norepinephrine as well. The non-stimulants do this less so. Stimulant isn't actually an accurate way of describing what it actually does to the brain, though. In some areas of the brain, stimulant medication decreases brain functioning. In other areas, it increases brain functioning. They have a very rapid onset in terms of practical differences. So the stimulants usually work within 20 minutes. They also leave the system within a few hours. You don't want to be taking a stimulant before you go to bed because it'll keep you awake. The non-stimulants, the nice thing about them is even though typically they're not as effective as a stimulant medication, you can take them every day and not worry about it interfering with your sleep. Typically they take a little bit longer to show an improvement, however. So I hope that clears up some of the differences. And to be honest, even though these medications have been around for decades, we don't completely understand how they work. But I will say this, that these medications were not actually developed for ADHD. Almost every psychiatric medication out there was not developed for a psychiatric problem. They happened to be developed for something else, and it turned out anecdotally that they worked in ADHD or depression and so forth, and then they started doing in more targeted fashion, the pharmacological companies to assess them. So what is neurostimulation? So neurostimulation is usually this idea that there's a current in the brain. It's been used for depression for quite a while, and I think there's actually good evidence for that. They use it in disorders like Parkinson's as well. There's deep brain stimulation. That's usually for something like Parkinson's and issues like that, where it's you need a neurosurgeon to implant it in the brain. But there are things like transcranial magnetic stimulation, or known as TMS. There are literally, I haven't looked at them myself, but I've been told you can literally find these things sold on Amazon. I wouldn't do that, because we don't know, there's no evidence at this point. Okay. And so they vary in terms of the modality, how they work, but the idea is that they target specific areas in the brain. And that's why it's so exciting, is because they can be so targeted. Whereas the other medications, they weren't developed for these areas of particular issues in mental illness, and they are not informed by neuroscience. And also that means they potentially have many more side effects. Whereas we don't know about all the potential side effects of neurostimulators because it's so new, but potentially they have fewer side effects, and that's what I think is so exciting, is that they can be targeted and so forth. So DTT, evidence against cause anxiety. Was that, I don't know, what is DTT? Oh, discrete trial training. You want to do that? That was my first, what I was trained in was DTT, was discrete trial training.
Do it. The evidence is pretty positive for discrete trial training, and I have not seen any evidence that it causes anxiety. I think the thing to remember about all the evidence-based practices and all treatments in general is that they can be done well and they can be done poorly, regardless of the name. And so again, we need to really look at behavior of the person who's receiving the intervention. Is it, are they enjoying it? Are they not enjoying it? Once they kind of understand the pattern and get used to it, and how well is it being implemented? So you want to look for things like, are there clear goals set up? Are data being collected on how well the progress is being made to meet the goals that were jointly developed by the parents, the individual, and whoever's providing the intervention? Is someone, like if it's an evidence-based practice, you want to say, do you have a manual for that? Like that's a really good question to ask someone who says they're using an evidence-based practice. Are they monitoring, especially because oftentimes in-home programs, there's someone supervising and then there's lots of people actually implementing the intervention. So what's the supervision like? Is someone monitoring that? And is the family really involved in monitoring the progress and setting up the goals and delivering the intervention? So those are the kinds of quality things you want to look for to help determine whether an evidence-based practice is being used the way it's intended and adapted in ways that work for the setting and the child and family. Does that make sense? So let's see. Someone asks, ABA and PECS is all my school district thinks is the only method. Is this common because this is the in thing? Well, PECS is an evidence as a practice based on applied behavior analysis that uses pictures for communication. And we have some nice evidence that for very young kids, it doesn't get in the way of language and it gives them a way to communicate before they have words. And so I think that's why many districts use it. Again, it can be used well or it can be used poorly. And similarly, ABA can be a narrow range of practices that are discrete trial, or it can be broadly used and it can be used poorly or it can be used well. And so if a district is using these practices very well and individualizing them to the student and it's working for families, I think that having them do it well is a good thing. But they aren't the only methods, and so if you have concerns about that for your child or family or yourself, then I think that's something to bring up with your district, your team at an IEP meeting. Someone wanted to know opinion about the Sunrise Autism Program. There just isn't a lot of evidence for or against the Sunrise program, and the procedures aren't well operationalized. It hasn't been replicated in other places, so it's hard to recommend a program when we have evidence-based practice that doesn't have clear procedures and evidence and is also very expensive. Makes me wary, but there's not evidence against it either, so if it's something it's like Julie was saying about the alternative practices, to speak with your providers, your physician about it, and determine whether it would work for your family and fits with your family values.
There's a question here about the relationship between ADHD and autism. And I can just say that there seems to be a higher prevalence of both disorders within families. And as I said earlier, we certainly see overlap, to some people with autism also have ADHD symptoms. What I've noticed personally in some of my clinical work is that occasionally we'll all have children who had early intervention and were diagnosed with autism, and they responded very well. And then as they become middle school age and high school age, they have some of the more impairing symptoms are the impulsivity and the problems with attention and the problems in school and so forth. So that's something we're learning about. We actually have a very large project with Irva Hertz-Picciotto and Debbie Bennett. It's a large epidemiological study called Recharge. It's part of this ECHO, so ECHO is a very wide project, probably 70 plus sites in the country. And we're looking at children who were identified as having autism, neurodevelopmental disorders without autism and typically developing. And we're also looking at their ADHD symptoms over time and how these change when they mature. So hopefully in the upcoming years, we'll have a lot more information about their relationship and so forth. And I think you were probably involved in that project as well.
Yeah, and I think one of the things we could just point out, particularly those of you who have older children with autism, is in the DSM-4, you couldn't officially have both diagnoses. You either had autism or ADHD, and they weren't considered comorbid, even though clinically we know that lots of kids have both. So in the DSM-5, it is now possible that you can have both legally or officially. So I think that was always confusing for for all of us, why you could only have one and not.
Although we saw it clinically and parents saw it, it was just that we couldn't give that diagnosis and we couldn't turn that into the insurance company with with both.
Crazy systems of care. So just in vein, here's another question. How do you tease out ADHD from other underlying challenges like dyslexia? So I think you started to touch on that, and maybe you could do a little more.
Sure. So in a very concrete way, the way we look at dyslexia is considered an academic learning disorder. We administer an IQ test, and we administer academic tests. So dyslexia is more considered in the reading area, so we would administer tests related to the factors or the processes related to reading, so phonemic issues and comprehension and so forth. And what we do is we compare how well they do on the academic tests to their what would be expected intellectually, and as well they have to be with showing impairment in terms of a certain degree. The other issue for me in a concrete way before I even get to that point, if I hear from a family that the challenges a child is having is only in school and these challenges are not happening at home, that makes me much more suspicious that this really is something this is more having to do with a learning disorder, and such as dyslexia. Dyslexia, if they have dyslexia and they don't have any problems with numeracy, with math and so forth, then that's even easier to tie down, although your reading impacts everything, almost everything one does in school. So.
Okay, thanks. One more ADHD question. What training should parents look for when asking or deciding on a psychologist?
That's a good question. I think in some ways it's like almost any treatment provider. You want to know that they've worked with a lot of cases with ADHD. You want to know that they're up on the latest information, that they continue to do their continuing education. They know it's out there. They don't just simply, if it's a psychologist, they're not prescribing medication. So, but you want to know that they understand different behavioral programs that are out there. Depends on the age, as we mentioned earlier. There's some procedures that are better for the younger children. So they have an awareness about, like I said, the latest research and so forth in terms of treatment. They have familiarity with accommodations and so forth in the schools. That's important as well. And that they're not just doing talk therapy. If they're telling you that they want to see your child for individual therapy or play therapy on a regular basis, then look for another provider, because those treatments we know that don't work. Even social skills, we know social skills works well for autism, but for ADHD it does not. So if your child is between the ages of 4 and 12 or so, then they should be working with you as a parent and then teaching you how to use and apply those behavioral principles across different settings. So again, one-on-one therapy, if they're suggesting that, then that's not the right person. But if your child has problems with anxiety as well as ADHD or some other issue, depression, then that makes more sense. I hope that was helpful.
So this is sort of similar, and it addresses both ADHD and ASD. What training would you recommend districts invest in for their psychologists? Captain.
Yeah, so I didn't talk about evidence-based identification of autism, but one of the things I think that is important for school psychologists, especially to reduce disparities for kids who may not have a medical diagnosis of autism, is you can access school services with a school classification of autism. And so investing in evidence-based ways of identifying autism, and probably ADHD as well, is very important, I think, for schools. And then I think really learning how to coach the people who will be using the interventions is a really helpful thing for school psychologists. So whatever interventions the school has decided to invest in, and I think that there are a range of good ones, training the school psychologists so that the teachers and speech pathologists and everyone who's using the intervention on that team has someone who can do that monitoring of whether they're doing things correctly and how to adapt it, really would be amazingly helpful, and I think can work well if the school psychologist has the time for that. And I think the third thing that was really helpful for school psychologists and anyone on an IEP team is to really learn culturally appropriate practices and how to listen and engage families in having them help set up the IEP and the program in a really meaningful way, because we know that improves outcomes, especially if the school can provide some parent coaching, and I don't think as educators we are well trained in how adults learn and how to kind of develop collaboration. We're trained in how to work with kids, and so I think that that can do a lot for child outcomes, is engaging families.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.